Imagine a world where um, a single medical breakthrough just completely changes things, gives millions of people their lives back, really.
Mm,
Where, tremors stop, that stiffness eases up, and people can move freely again, talk, connect with family. It's all restored.
yeah,
For so many people dealing with Parkinson's disease, levodopa or L-Dopa was exactly that. I mean, just a revolutionary lifeline. It changed everything about their daily life.
it really did. A massive shift.
But like with a lot of these really powerful treatments, the whole story of levodopa, it isn't just about that initial amazing success, is it?
No, not at all. It gets much more complicated.
It's a much richer, more complex story, a reality that kind of unfolds over the long haul,
Mm,
one that needs constant innovation, a deeper understanding of how it all works.
precisely.
So today, on the deep dive, we're really jumping right into that fascinating, super intricate world of levodopa.
Yeah, let's do it.
And this isn't just skimming the surface. Our mission here is to really unpack what makes this drug so uniquely effective, but also explore those significant challenges that come up over time.
Right.
And importantly, spotlight the cutting edge strategies researchers, clinicians are working on right now to make it even better, pushing the boundaries for Parkinson's care.
That's exactly right. And our deep dive today, it's grounded in, well, a pretty solid collection of PubMed articles. Really eliminating stuff.
So proper scientific sources.
Oh, yeah. Studies, comprehensive reviews.
Yeah.
They've meticulously looked at levodopa's basic mechanisms, its, profound benefits, which are often life-changing,
Sure.
but also, yes, the complexities, the challenges that definitely come up with long-term use.
So you've sifted through all that.
We have, yeah. We've gone through these papers, pulled out the most important bits, the key insights, basically distilled years of research down so you get a really comprehensive but hopefully digestible picture.
Okay, great. So as we get started, our mission is clear. We want you to really grasp not just what levodopa does, but how it works fundamentally in the brain,
Hmm.
and understand the complexities patients and doctors deal with every day, and also see the truly innovative things being developed to maximize the good stuff while trying to minimize the drawbacks.
Yeah, it's quite a testament to, human ingenuity, scientific dedication, that constant drive to improve quality of life for millions.
It really is.
Mhm.
Okay, let's dive in.
Let's go.
So to really get levodopa, we have to start at the beginning, right? Its revolutionary start. When it first appeared, it wasn't just another pill. It was like a seismic shift. What made it such an absolute game changer back then, especially that incredible effectiveness early on?
It's genuinely hard to overstate the impact. Levodopa really pioneered the whole idea of symptomatic therapy for Parkinson's.
Right. Before that,
Yeah,
what was there?
honestly, very little. Options were incredibly limited, offered maybe marginal relief,
Yeah.
and the disease just, progressed. Quality of life almost inevitably declined. So the research consistently calls Levodopa a dramatic and revolutionary breakthrough in medicine. It just fundamentally changed the outlook for Parkinson's patients,
Yeah.
offered symptom relief that was previously just unimaginable.
And what's really striking is even now, decades later, with all the new drugs and research, levodopa still holds that top spot, doesn't it?
It does.
Our sources are pretty clear. It remains the most effective drug for Parkinson's, especially for controlling those classic motor symptoms we think of.
Precisely. Its transformative clinical benefits are, well, they're undeniable.
Right.
Think about the core signs. Akinesia, that difficulty starting movements,
Yeah.
rigidity, the stiffness that makes simple things so hard,
Mm-hmm.
and tremor, that debilitating shaking. Levodopa markedly improves all of them. It doesn't just lessen them. It often gives patients back a significant amount of motor control, restores functional independence.
But the impact goes beyond just movement, doesn't it? It's
Yeah.
about their overall ability to function and, crucially, their quality of life.
Oh, absolutely.
I was really struck by one study finding that mortality due to Parkinson's disease has decreased significantly after the introduction of L-Dopa treatment.
Yeah.
That's huge, isn't it? It suggests it's not just managing symptoms day to day. It might actually be extending life expectancy. What a legacy.
It is. And that's a critical point for anyone trying to grasp the full scope here.
Yeah.
We're talking about a drug that improves daily function and potentially changes the disease's long-term path, letting people live longer, more engaged lives.
Hmm.
And the improvements aren't just the big motor things. Even axial signs like reduced facial expression, hypomimia, they call it.
Right, the mask-like face.
Exactly.
Yeah.
Even that can be surprisingly responsive to levodopa. Imagine being able to show your emotions more freely again. That hugely impacts how you interact with the world, physically and emotionally.
That's a really subtle but powerful detail. It shows how deeply levodopa affects those neural pathways. And even more fascinating, our sources mention something about cognitive function. That levodopa improved response inhibition performance in early stage patients.
Yes, that was interesting.
It suggests it enhances salient signal processing. What does that actually mean for a patient day to day?
It really highlights that dopamine's reach goes way beyond just movement. Response inhibition is basically your ability to stop an automatic response when it's not appropriate, like stopping yourself reaching for something or pausing before you speak impulsively.
Okay.
For someone with Parkinson's, where cognitive flexibility can be a challenge, improving this can mean better decision-making, less impulsivity, just a greater sense of control. It shows dopamine's complex role in higher brain functions, not just motor stuff.
So it's not just getting the body moving, but helping the brain decide how to move, or even when not to. But it's not a magic bullet for all movement aspects, right? There was a nuance about postural control.
Absolutely, good point. While it generally improves mobility, one study gave us a more nuanced look at posture, specifically just standing still. It found that when on levodopa, patients tended to use more of a hip strategy for balance compared to when they were off the medication.
A hip strategy, meaning
Meaning they rely more on larger movements from the hips and trunk to stay balanced, rather than finer adjustments at the ankles. Normally we use a mix. While their overall sway, how much they wobble, might sometimes even slightly increase on the drug, this shift shows a change in how the body compensates.
okay.
So while the drug helps overall movement, the underlying mechanics of balance might change. It highlights that even helpful interventions can have complex biomechanical effects. It's not a complete fix for balance, maybe more of a recalibration, and it can vary between patients.
That's a great example of how a deep dive finds those subtle but important distinctions. It helps the body adapt, but maybe differently than you'd expect. Okay, let's talk about the start of treatment. How quickly and consistently does it work in those early days?
For many, that early phase, maybe the first 2 to 5 years, is often described in the research as a period of successful, smooth, and stable clinical benefit.
The honeymoon period, right?
Exactly, the honeymoon period.
Mm.
Patients get significant relief, the meds work reliably, quality of life improves dramatically. It's this golden window where the drug just works optimally, providing consistent control.
And I guess researchers are always trying to make that on-time kick in even faster, get relief quicker.
Definitely. Speed of onset is huge for patients, especially if they get sudden off periods.
Yeah.
Our sources mention formulations like Levodopa, that's levodopa methyl ester, combined with carbidopa.
Right. What's the edge with that combo?
Well, they're designed to get a significantly shorter latency to on compared to standard levodopa carbidopa. That methyl ester in levodopa helps its solubility and absorption.
Ah, so it dissolves and gets absorbed faster.
Exactly. Gets into the bloodstream, into the brain quicker, leading to faster symptom relief. For someone waiting for their meds to work, saving even a few minutes feels like a big deal. It's a direct response to a real patient need.
Makes sense. A very practical innovation. And thinking about its overall safety profile, just initially, before we get into the long-term stuff, how do the benefits usually stack up against immediate drawbacks?
Yeah, it's vital to remember that, especially early on, the overall benefits generally far outweigh potential drawbacks, even considering the motor complications like dyskinesias that can eventually emerge.
Okay.
The immediate, profound improvement in motor symptoms and quality of life is just so significant that, for most people, it's clearly the best option available.
That's crucial context. I also saw something interesting about managing potential cardiovascular risks, which isn't the first thing you think of with a Parkinson's drug.
Right.
One study mentioned patients on Medipar, levodopa formulation, had higher homocysteine levels initially. That's a cardiovascular risk factor.
I think this is.
With things like methylcobalamin and folic acid, those levels dropped significantly. And even better, they saw fewer new cerebral ischemic lesions like mini strokes.
Exactly. It shows a more holistic approach to care. Homocysteine is an amino acid, and high levels are linked to heart disease, stroke risk.
So supplements helped.
The fact that supplementing with methylcobalamin, that's a form of B12 and folic acid, could lower those levels and potentially reduce these brain lesions, it speaks to how interconnected things are. Levodopa targets the brain, sure, but its metabolic pathways interact with the whole body. Understanding that lets doctors intervene strategically, manage potential risks, even ones that seem unrelated to movement, enhance overall well-being.
That really underlines the need for comprehensive care, doesn't it? Okay, let's pivot now to the other side of this powerful drug. As amazing as levodopa is, long-term use brings real complexities, the double-edged sword, as you called it.
Hmm.
What are the main long-term challenges patients face?
You've hit the core issue. The biggest one, and maybe the most distressing for many, is the emergence of motor complications, specifically the on-off fluctuations.
Right. Explain that phenomenon.
It describes these unpredictable, often sudden shifts. You go from periods of good motor control when the meds are working, the on periods, to periods of poor control, the off periods, when the Parkinson symptoms, tremor, stiffness, slowness come roaring back, often abruptly.
That sounds incredibly disruptive. How common is this? Is it just a few people or?
Unfortunately, it's remarkably common. The research is consistent. Most patients on long-term levodopa therapy will, sooner or later, develop response fluctuations.
Yeah. Most patients.
Yeah, it's almost an inevitable part of the journey for many people on chronic levodopa. Imagine trying to plan your day, social events, even just a walk, constantly wondering when the next off might hit, how bad it will be. That unpredictability really hammers quality of life.
And it's not just one kind of off, is it? Our sources mention different patterns.
Yes, there are subtypes. The common ones are delayed on,
Meaning?
meaning it takes much longer than usual for a dose to kick in, so you're stuck in an off state for ages.
Frack.
And then there's no on, which is even worse.
Yeah.
The dose just completely fails to work. You take it, you wait, nothing happens, you're functionally impaired.
Ugh.
There's also wearing off, where the benefit fades before the next dose is due. But those unpredictable delayed on and no on are particularly tough.
That sounds incredibly difficult. What's causing these fluctuations? Is it just the disease getting worse, or is it something about how the body handles levodopa?
It's a mix, but pharmacology plays a huge role. Levodopa itself chemically has pretty poor solubility, and it's mainly absorbed in one specific bit of the small intestine, the duodenum.
Okay.
Now, in advanced Parkinson's, many people get slowed or erratic gastric emptying. Food and meds just sit in the stomach unpredictably long.
Ah, bottleneck.
Exactly. If levodopa isn't delivered consistently to the duodenum, its absorption becomes super variable. Erratic absorption leads directly to unpredictable on-off effects, like trying to fill a bucket with a hose that keeps sputtering on and off. Can't rely on it.
A literal traffic jam in the gut, messing with the drug delivery. And then what's happening in the brain itself that makes it so sensitive to these ups and downs?
Yeah, so pathophysiologically, the research points to pulsatile stimulation of striatal dopamine receptors as a key factor.
Pulsatile stimulation. Okay, break that down.
Right. Imagine the brain's dopamine receptors, the little logs that dopamine keys fit into, as really sensitive musical instruments. Ideally, they want a smooth, steady flow of dopamine, like a constant note.
Right.
But with oral levodopa doses, especially as the disease progresses and the brain loses its own dopamine storage capacity, the receptors don't get that smooth signal. They get sharp peaks when the dose kicks in and deep troughs when it wears off.
Okay, so jolts of dopamine.
Exactly. This erratic, pulsatile jolting over time causes changes in the receptors and circuits. They get hypersensitive to the peaks, leading to dyskinesias, which we'll get to, and they become unresponsive during the troughs, causing the off periods. It's like blasting a trumpet right next to the instrument, then suddenly silence. It messes up its normal function.
That's a great analogy. So the brain isn't just missing dopamine. The dosing schedule itself kind of trains it to react erratically. Makes sense. Now, the other big motor issue, levodopa-induced dyskinesias, LAD. Define dyskinesias for us.
Dyskinesias are abnormal involuntary movements. These aren't tremors. They're usually more fluid, maybe writhing or dance-like movements, often affect the limbs, trunk, or face.
And they can be mild or severe.
Exactly. Range from tiny, fidgety things patients might barely notice to severe, uncontrollable movements that can be just as disabling, sometimes more so, than the Parkinson's symptoms themselves.
Wow. And how common are these, especially over time?
Very common with long-term use.
Yeah.
Our sources are clear. Their prevalence increased with increased duration of treatment. So the longer you're on levodopa, the higher the chance of developing some dyskinesia. It's a major long-term challenge.
And peak dose dyskinesia sounds particularly bad. What's that?
Yeah, peak dose dyskinesia is a big treatment hurdle. Like the name says, it happens when the levodopa level in the body is highest at its peak effect.
So the time you most want the drug to work
Is also when these involuntary movements are strongest. It's a cruel irony. The very thing providing the on-time triggers these disruptive movements.
What's the mechanism behind that? It seems linked to that pulsatile stimulation idea.
It is, yeah. The underlying mechanism is complex, but the evidence points toward LID coming from Overstimulation of dopamine receptors located on the GABAergic medium spiny neurons, MSNs, or the dorsal striatum.
Whoa. Okay, let's unpack that. GABAergic medium spiny neurons. Dorsal striatum.
Right, neuroscience jargon alert.
Yeah.
Let's simplify. Think of the brain's motor control like a highway system. The striatum is a major central hub.
Okay.
Inside this hub, medium spiny neurons, or MSNs, are the main output cells, like traffic controllers deciding if a movement signal gets a green or red light. GABAergic just means they use GABA, an inhibitory signal like hitting the brakes.
Got it. Brakes on movement.
Now, there are two main routes through this hub. A direct pathway that basically says go for movement, and an indirect pathway that says stop. In Parkinson's, not enough dopamine means the go pathway is underactive, stop is overactive. Result: slowness, stiffness.
Makes sense.
When you add levodopa, you're trying to rebalance that. But the pulsatile delivery, plus changes in those MSNs due to the disease, can cause overstimulation of dopamine receptors, especially hitting that direct striatonal pathway too hard.
So the go signal gets stuck on?
Essentially, yeah. It stays on too long or too intensely, leading to those uncontrolled involuntary movements, dyskinesias. Too much dopamine signal in specific sensitized parts of the circuit.
So you're trying to fix the lack of dopamine, but sometimes overshoot in these specific pathways. What a delicate balancing act. Okay, moving beyond motor problems, what about non-motor complications? Are there other big long-term effects?
Oh, yes. Non-motor complications are hugely significant, really impact quality of life. Neuropsychiatric effects are a big one, things like hallucination, psychosis. These are recognized long-term issues, often linked to chronic dopaminergic therapy generally, especially if dopamine agonists are used with levodopa, but levodopa itself can contribute.
That's a really tough thing for patients and families to deal with. But I saw an interesting point in the sources about hallucinations. It wasn't always a straightforward drug effect. More complex.
That's a critical distinction, yeah. One study found that neuropsychiatric disorders in PD are more likely an interaction between levodopa and the disease state than a consequence of sensitization to repeated dopaminergic therapy.
So it's the drug plus the diseased brain.
Exactly. It's not that levodopa causes hallucinations directly like, say, an allergy. It interacts with a brain already made vulnerable by Parkinson's neurodegeneration. That vulnerability plus the dopamine boost creates the conditions.
Interesting.
And fascinatingly, giving high-dose levodopa intravenously didn't trigger hallucinations in people who already had them, which supports this idea of an interaction with a pre-existing state, not just inducing them fresh.
That's really careful thinking, understanding it's not simple cause and effect. And speaking of unusual effects, I was pretty surprised by case reports of compulsive risk-seeking driving behavior from people self-administering high doses of L-Dopa, classified as a new behavioral phenomenon in dopamine dysregulation syndrome. That's wild, almost like an addiction.
It certainly is unexpected. It just shows how deeply dopamine pathways influence complex behaviors, reward, motivation, impulse control, far beyond just movement.
Right.
In these rare cases, the high-dose levodopa, meant for motor symptoms, seem to hijack the reward system, leading to incredibly risky compulsive actions. It shows the unpredictable reach of these neurotransmitter systems when they're out of balance. And related to that, our sources also noted some patients, 2 out of 6, in one long-term study developed acute delusional hallucinatory disorders when dopamine, an MAOB inhibitor often used alongside levodopa, was added later in their illness.
So combining drugs can trigger things too.
Yes, it underscores the need for really careful titration and monitoring when you combine different drugs affecting dopamine pathways.
Definitely. What about withdrawal risks? Is it dangerous to suddenly stop high-dose levodopa?
Absolutely. Critical safety concern. Our sources had a striking case report of neuroleptic malignant syndrome, NMS.
NMS, okay.
It happened from suddenly stopping high-dose 1,200 milligrams a day levodopa. NMS is rare, but potentially fatal. High fever, rigid muscles, altered mental state, autonomic chaos.
Wow.
It's basically a massive dopamine withdrawal that overwhelms the body. The report mentioned electroconvulsive therapy, ECT, was needed successfully in this severe case. Really highlights why you never stop this medication abruptly. It needs careful, gradual management.
A very stark reminder of its power. Okay, beyond motor and neuropsychiatric stuff, what about the autonomic system? Does levodopa help with things like blood pressure control, which often go haywire in Parkinson's?
Yeah, autonomic dysfunction is common in PD, often under-recognized. Our sources detail how specific tests, Valsalva, deep breathing, hand grip, orthostatic tests,
Checking heart rate and blood pressure responses.
Exactly. Those tests showed significantly smaller responses in PD patients versus healthy people. Clear sign of impaired autonomic function.
And does levodopa fix that? Like it helps movement?
Not really, no. And that's important for managing expectations.
Yeah.
Our sources show a pattern. Sympathetic impairment, the fight or flight stuff like blood pressure, tends to be worse in patients with more rigidity and slowness and happens earlier.
Huh.
Parasympathetic impairment, the rest and digest functions develops later. Both get worse as the disease gets more severe.
Okay.
But critically, the research indicates chronic levodopa treatment does not markedly influence cardiovascular autonomic responses. Orthostatic issues, blood pressure drops on standing, often get worse with disease duration, regardless of the medication.
So levodopa is a lifesaver for movement, but doesn't really touch these autonomic problems. They need separate management.
Exactly. Crucial distinction.
Are there any other, maybe more niche or unexpected side effects, things happening at a molecular level?
Yeah, a couple of interesting ones. One finding is about potential pro-oxidant DNA breakage.
DNA damage from levodopa.
Potentially, yeah. It seems L-DOPA can interact with copper, He2I, in the body, and this interaction could theoretically contribute to cellular damage, a possible neurotoxicity mechanism.
But
It's complex, because levodopa also seems to prevent DNA damage caused by iron and copper through other ways.
so it can cause and prevent damage.
It seems like it has this dual role, depending on the exact chemical environment, an intricate biochemical dance, not simple good or bad.
Fascinating. Like it's walking a tightrope at the molecular level.
Pretty much.
Yeah.
And another side effect noted, this time with a more advanced delivery method, polyneuropathy.
Nerve damage in the limbs.
Yeah, damage to peripheral nerves. Reported in some patients getting LCIG infusion, the levodopa-carbidopa intestinal gel,
What causes that?
possibly linked to deficiencies in vitamins B6, B12, folate, and maybe those high homocysteine levels we talked about earlier.
Ah, so the infusion process itself might affect vitamin levels.
It seems possible, yeah. Again, it highlights how crucial comprehensive nutritional monitoring is with these long-term intensive therapies. Managing systemic effects is just as important as managing the disease itself.
Okay, so it's crystal clear. Levodopa, still the cornerstone, incredibly beneficial, but long-term use brings major challenges. Motor fluctuations, dyskinesias, neuropsychiatric issues, even these subtle molecular things, which leads us perfectly into the really exciting part. How are people evolving strategies to optimize levodopa, make it better, manage these issues?
This is where the innovation is really happening. The medical community is relentlessly trying to mitigate those long-term problems while keeping the benefits. One main approach is pharmacological augmentation, adding other drugs and delivery innovations.
Okay.
A key strategy here uses COMT inhibitors, and tacopone is a common one. They're interesting because they don't add dopamine. They basically stop levodopa breaking down too early.
Like a bodyguard for levodopa, letting more of it get to the brain.
Exactly. They inhibit the enzyme catechol-O-methyltransferase, COMT. It's one of the main enzymes that chews up levodopa in the gut and bloodstream before it reaches the brain.
So blocking that enzyme.
Lets more levodopa get where it needs to go, makes each dose more efficient, lasts longer. The benefits are measurable. Sources show a big 38% to 40% increase in levodopa's area under the curve, or AUC.
Area under the curve. What does that mean for a patient? Why is a 38–40% jump good?
Think of AUC as the total drug exposure over time. Higher AUC means more drug in the bloodstream available to the brain for longer.
Okay.
So that big increase translates directly to more on time, a smoother, more consistent effect. Clinically, one study noted a 16% decrease in overall disability.
That's a significant.
Plus, CMT inhibitors slashed the levels of levodopa metabolites, like 3-O-methyldopa, by around 44%.
And why is reducing that metabolite good?
Because 3-O-methyldopa is basically a waste product that competes with levodopa to get across the blood-brain barrier. Reducing it by almost half means less competition, more efficient delivery of the good stuff to the brain, smoother effect. Newer COMT inhibitors, like opicapone, are specifically used as add-ons to reduce that end-of-dose motor fluctuation, that wearing-off problem.
Ah, a targeted fix for a specific issue. What about MAOB inhibitors, selegiline or deprenyl? How do they fit in?
MAOB inhibitors like selegiline work differently. They block monoamine oxidase B, another enzyme that breaks down dopamine inside the brain.
So they make the brain's own dopamine, or dopamine from levodopa, last longer.
Exactly. Preserve the existing dopamine. What's really interesting is their role early on. Starting with just an MAOB inhibitor can actually delay the need for L-DOPA treatment altogether.
Really? By how much?
One study found it delayed needing L-DOPA by 545 days versus 372 for placebo. That's almost an extra half a year before starting the potentially more complicated levodopa.
Wow, that's huge for patients.
And even once someone is on levodopa, MAOB inhibitors can reduce the amount of daily L-DOPA required, often allowing a 20–50% dose reduction. The long-term hope. They might render Parkinson's disease more benign, with long-term symptom control, fewer late complications, and increased life expectancy. It's potentially about altering the disease course, not just symptoms.
That's incredible potential, delaying levodopa, maybe making the disease milder, extending life. Okay, what about dopamine agonists? How do they play into optimizing treatment?
Dopamine agonists are different again. They don't supply dopamine's precursor. They directly stimulate the dopamine receptors themselves, mimicking dopamine's action.
Okay.
This gives continuous dopaminergic stimulation. That continuous part is key because we think the pulsatile nature of oral levodopa adds to motor complications.
Right.
So agonists are used early on, sometimes alone, maybe reducing future dyskinesia risk, or they're added later to help smooth out fluctuations and cut off time.
And there's a specific one, apomorphine, that sounds pretty dramatic, almost like a rescue drug.
Absolutely. Epomorphine, usually given by injection under the skin, has a unique critical role for people with severe refractory levodopa-related on-off fluctuations.
Refractory meaning hard to treat.
Exactly. Apomorphine is incredibly fast-acting, can cut daily off time by about 50%. It's often used literally as a rescue for those sudden, awful off states when someone needs rapid relief.
So if you suddenly freeze up.
An injection can potentially reverse that within minutes. It provides dramatic rescue from difficult off situations. But there's a caveat. Long-term use might increase dyskinesias or postural instability in some, so it needs careful patient selection.
Okay, so even though agonists aim for continuous stimulation, they can still sort of contribute to dyskinesia or prime the brain for it? That feels a bit counterintuitive.
It's a very subtle point. Shows how complex brain adaptation is. While the pattern from agonists is generally more continuous, which should reduce dyskinesia, it's not perfect. Our sources note that switching from L-DOPA to an agonist like ropinirole might trend towards reducing dyskinesia intensity, a potential plus. But the key insight is agonists can still prime for dyskinesia. They can make those dopamine receptors, our musical instruments, more sensitive to future dopamine input, including levodopa. So while they might not cause the full expression of dyskinesia like L-DOPA can, they might lay the groundwork. Maintaining that delicate dopamine balance is just tricky.
Fascinating. Not just the amount of dopamine, but the pattern and the brain's readiness to respond. Okay, moving beyond adding drugs, what about just optimizing how standard oral levodopa gets absorbed? Practical things.
This is super important because absorption problems drive fluctuations. To tackle poor solubility and slow stomach emptying, practical tips from our sources include taking multiple small doses through the day, not a few big ones.
Okay.
Preferably on an empty stomach, so food doesn't interfere. And often crushed and mixed with a lot of liquid to help it move faster and get absorbed in the duodenum. Simple changes, potentially big impact.
Sounds like adjustments to the daily routine, but worth it. And diet is a big factor too, right? Specifically protein?
Absolutely crucial and often overlooked. Protein, specifically some amino acids in it, competes with levodopa for absorption in the gut and transport into the brain.
Ah, competition.
So restricting daily protein intake and shifting protein intake to the evening can significantly cut off time. One study showed after-meal off periods dropped from 79 minutes to 49 minutes with this strategy.
That's 30 minutes less off time just by shifting protein.
Huge improvement in functional time. Using low-protein products for breakfast and lunch also helps give the morning and midday levodopa doses a clearer path. Lets people function better during active hours. A great example of how lifestyle tweaks affect medication effectiveness.
Amazing. Any really unexpected factors affecting absorption? Something surprising like bacteria.
This one is quite interesting and, yeah, surprising. Research suggests Helicobacter pylori infection, the bug linked to stomach ulcers, might actually be associated with a decreased occurrence of symptom fluctuations.
Wait, an infection helps with fluctuations? That sounds backwards.
Totally counterintuitive.
Yeah.
More studies are needed for sure. But the theory is H. pylori might change stomach pH or motility in a way that leads to slower, more sustained levodopa absorption. Paradoxically, this might smooth things out, make delivery less pulsatile. A fascinating, unexpected gut-brain link needing more research.
Mind-bending stuff. Okay, what about really advanced delivery? Continuous infusion therapies. Sounds invasive, but maybe revolutionary for severe fluctuations.
For patients with advanced Parkinson's and severe fluctuations, despite optimized oral meds, levodopa-carbidopa intestinal gel, or LCIG brand name Duodopa, is a major option.
How does that work?
It's a gel form of levodopa-carbidopa continuously pumped through a surgically placed tube directly into the small intestine. Bypasses the stomach emptying problem entirely.
And the benefits must be substantial to justify that surgery.
They are. For the right person, it's life-changing. LCIG gives significant improvements. Much less off time, more on time, without bad dyskinesia, better daily living activities, better quality of life. It provides that continuous stimulation the brain needs, leading to smoother, predictable control.
Wow.
It often lets patients stop other oral Parkinson's drugs too, simplifying things.
Right.
But, like we mentioned, crucial to watch for that potential polyneuropathy linked to B vitamin issues. It needs proactive nutritional management.
Right. That brings us to surgery itself and neuromodulation, deep brain stimulation, DBS. Sounds like high-tech precision stuff. How does it work? Is it effective?
DBS is a remarkable example of precision medicine, yeah. Surgeons implant thin electrodes into specific, tiny, deep brain areas, usually the globus pallidus internus, GPI, or subthalamic nucleus, STN.
Okay.
These wires connect to a small battery pack, like a pacemaker, under the skin. It delivers continuous, low-voltage electrical pulses. A brain pacemaker, basically re-regulating abnormal brain activity.
And clinically, how much better do people get? What does it target?
DBS offers really significant benefits, especially for patients whose motor symptoms still respond to levodopa, but they have severe fluctuations and dyskinesias that meds alone can't control well. Sources show it improves motor scores, the UPDRS-3, by an average of 35.3%. That's a big jump in function. Crucially, it also significantly reduces levodopa-induced dyskinesias and tremor. Often lets people cut back on medication too, which can lower long-term costs.
That sounds life-altering. How does it work at the network level? What's happening to brain activity with those pulses?
This is where DBS gives us cool insights. In Parkinson's, certain brainwave patterns, beta oscillations, are abnormally strong in the basal ganglia, linked to slowness and rigidity.
Right.
DBS effectively reduces those bad beta waves, helping symptoms. Conversely, it might prompt high-frequency gamma oscillations, sometimes linked to normal movement, sometimes abnormal. But DBS helps rebalance things. It's like retuning the brain's rhythm, getting the orchestra back in sync.
Great analogy, recalibrating the brain circuits. And can you combine DBS with other things like that intestinal gel, LCIG?
Yes, absolutely. They're not always either. There's a strategy of adding LCIG after DBS if someone develops new problems or finds DBS doesn't cover everything. It shows how clinicians layer these advanced tools, personalizing treatment to get the best possible outcome.
Powerful stuff. Okay, finally, let's look ahead. Emerging therapies, new research insights. What's on the horizon that could make levodopa even better or offer new ways to tackle its challenges?
Super exciting area. A key path is targeting glutamate pathways. The idea is increased extracellular glutamate may contribute to L-dopa-induced dyskinesia.
Glutamate, the brain's main accelerator chemical, too much of it fuels dyskinesia.
That's the thinking. While dopamine shortage is the core PD problem, glutamate imbalance, maybe too much excitation, seems involved in LAD movements.
So if too much glutamate is bad for dyskinesia, what's being tested?
Researchers are looking hard at metabotropic glutamate receptor, mGlu receptor drugs.
Right.
Specifically, mGlu5 negative allosteric modulators show promise.
Negative allosteric modulators, meaning?
They don't block glutamate outright, but subtly tweak the receptor's response, like turning down the volume, not hitting mute. Animal models show they can attenuate LAD while maintaining the anti-Parkinsonian effect of L-DOPA.
Reduce dyskinesia without hurting the middle benefit. That's the dream.
Exactly. Another cool angle, activating the glycine site on NMDA receptors using a glycine transporter 1 GLIT1 inhibitor. In marmosets, this reduced dyskinesia and psychosis-like behaviors. Totally new, non-dopamine targets for these complex problems.
Wow, going beyond dopamine. And what about serotonin? How does that system interact?
Growing understanding here, the serotonergic system, using serotonin for mood, sleep, etc., is definitely involved. It is known to contribute to levodopa-derived dopamine release.
Oh, wait, serotonin neurons release dopamine from levodopa?
Some levodopa gets taken up and converted by serotonin neurons, yes. And the release of this false dopamine from them can be dysregulated, contributing to fluctuations and dyskinesias. So the idea is, if we could control those serotonin neurons better, maybe we reduce side effects. Intriguingly, L-dopa can even promote non-vesicular releases of serotonin and dopamine.
Non-vesicular releases, what's that mean, quickly?
Normally, neurotransmitters are stored in little sacs, vesicles, released in controlled bursts. Non-vesicular release is more like leakage, less precise, more continuous. If dysregulated, could contribute to fluctuations. Understanding this opens new targets for stabilizing things. This interplay between dopamine, glutamate, serotonin, and it's a rich area for new drugs.
So it's the whole neurotransmitter orchestra, not just the dopamine section. Any other new drugs or formulations popping up?
Research continues. Drugs like zonisamide, an anti-epileptic, are being explored for LID, maybe through various neurotransmitter effects. Plus, ongoing work on new oral forms, innovative delivery beyond pills, patches, inhalers, oral films, trying to get better absorption, more stable levels. Always chasing that smooth, continuous stimulation without needing surgery if possible.
And diagnostics. Anything new for monitoring levodopa levels, maybe in real time? That could be huge for personalized dosing.
Totally key. Exciting work on highly sensitive sensors, things like electrochemical sensors, even nanogap sensors, to detect levodopa in biological samples.
So you could track levels easily.
If these mature. Yeah, could revolutionize monitoring, allow real-time personalized dose adjustments. Imagine a patient or doctor seeing levels fluctuate and tweaking the dose precisely. A new era of personalized Parkinson's management.
This has been an incredibly thorough deep dive. We've really journeyed from levodopa's initial, revolutionary promise, right through the complex, challenging dance of managing its long-term motor and non-motor effects.
And we've highlighted how ongoing, relentless research in pharmacology, genetics, even unexpected things like diet and gut bacteria keeps refining its use, improving lives. The dedication to optimizing this crucial drug is really inspiring, always seeking that balance, maximizing benefit, minimizing burden.
What's amazing is even with a drug this foundational, this studied, the discovery isn't over. It's constant learning, adapting, innovating.
Absolutely.
So as we keep refining treatments like levodopa for chronic conditions, what's the next unexpected biological interaction, you think? Or the next game-changing delivery method that completely shifts how we see these powerful drugs working, not just in the brain, but the whole interconnected body? What new aha moments are waiting out there in the next generation of deep dives?